I'm Richard Geer, Physician Chief of Surgical Oncology at Sarah Cannon. The decision about lumpectomy and mastectomy is ultimately yours. I mean, you make the decision. You're the one that's going to live with this. You're the one that, once it's done, the bridge is burned. You can't go back and undo a mastectomy. We can't do that. Now, you can always go do a lumpectomy and then later at some point in time have mastectomy, but the other way we can't do it. So we have to decide who's appropriate. The problem is it's taken us 120 years of doing breast cancer, and then when you're diagnosed, you have about 2 to 3 weeks to decide what you want to have done, and the decision's final in terms of what you do. I think a lot of women think that their risk of recurrence is extremely high, and that kind of puts them over into really wanting to have that done. There are some reasons why you should have it done. They have very extensive disease, more than one tumor in the breast. Again, a large tumor size to breast ratio, a genetic history of this. Sometimes our younger patients, we know our younger patients have a higher risk of local regional recurrence. Sometimes we'll let that happen. What we like to do with all patients is to do immediate reconstruction if we do mastectomy. And I think that meeting with the plastic surgeon, if you're having a mastectomy, whether you want reconstruction or not, is extremely important. It just gives you additional information about the best way to be treated in terms of going forward in your therapy, and also for peace of mind to understand what's involved with reconstruction. And you may have the conversation and go, no, I don't want to have that done. Let's just get this done. We'll worry about that later. I think either that's fine. There's a lot of different reconstruction methods, and I think there's a lot of really wonderful plastic surgeons out there that are really committed to breast reconstruction. It could be as simple as placing implants, could be what's called a latissimus dorsi flap, could be a tram flap, could be some of these new other types of flaps that we're using, but there's a lot of different ways to do that, and it really depends on your body type and your choice and the choice of the plastic surgeon to what's best for you. Once you've completed generally your surgery, radiation therapy, and oftentimes chemotherapy given by IV, if your tumor is ER, estrogen receptor, or progesterone receptor positive, generally the medical oncologist will prescribe you to take an anti-estrogen drug, something like Arimidex, tamoxifen, something along those lines. That drug is given for 5 years. So it's a once-a-day drug for 5 years. Most women tolerate it extremely well. However, some just don't tolerate it at all. And the reason why we've learned that it's a good drug is it will decrease your risk of developing recurrence of about 50%. Now, your risk may not be all that high, but continuing to decrease the risk that you would have a problem in the future. And certainly if you could tolerate it well, we do recommend it for patients.